I'd like to thank the organizing committee and the Association of Women Endoscopists for the invitation. Today, I'm very honored and excited to be speaking on a topic that is dear to my heart on obesity management and liver disease. Here are my disclosures. The goal for today's talk is to review the effect of the currently available obesity management on non-alcoholic fatty liver disease. We will start with a brief background on NAFLD and then discuss the effect of lifestyle modification, anti-obesity medications, and bariatric surgery on NAFLD. Since this is an endoscopy course, we will focus the majority of the talk on the effect of bariatric endoscopy on NAFLD. So why should we care about NAFLD? If you look at this obesity prevalence map, and the NAFLD prevalence map, you can see that the incidence of NAFLD mirrors the obesity pandemic. Currently, it is estimated that 25 to 30% of adults in the US have NAFLD. However, this prevalence increases to about 90% in patients with obesity. Traditionally, the only treatment for NAFLD is lifestyle modification. Here's a landmark study on this topic looking at 293 patients with NASH who underwent lifestyle modification. Liver biopsies were performed prior to and at 1 year following the intervention. At 1 year, 25% of the cohort achieved resolution of steatohepatitis. 47% had reduction in NAS, which is the sum of histology scores of steatosis, lobular inflammation, and hepatocyte ballooning. And 19% had regression of fibrosis. More importantly, this study showed that the degree of weight loss was associated with improvements in all NASH-related histologic outcomes. Specifically, if patients lose at least 10% of their baseline weight, 90% had resolution of NASH and about half of them had regression of fibrosis. However, less than 10% of the cohort were able to achieve this weight loss threshold. What about medications? Currently, there's no medication that's specifically approved for NAFLD-NASH. There are 2 medications that are under an FDA review for NASH treatment. These are resmetirom, which is a thyroid receptor agonist, and obeticholic acid, which is an FXR agonist. What about anti-obesity medications? Currently, there are 6 medications that are approved for the treatment of obesity as listed here, with a new kid on the block being semaglutide or Wegovy, which has gotten a lot of press with approximately 14% total weight loss at 1 year in its pivotal study. So let's look at the data on semaglutide on NAFLD. Here's a phase 2 RCT including 320 patients who were randomized to semaglutide 0.1 milligram weekly, 0.2 milligram, 0.4 milligram, or placebo. All patients had biopsy-confirmed NASH with F1 to F3 fibrosis. The primary outcome was complete resolution of NASH with no worsening of fibrosis. What the study showed was that semaglutide 0.4 milligram was superior to placebo at inducing NASH resolution with no worsening of fibrosis, 59% versus 17% respectively. However, there's no difference in the rate of improvement in fibrosis between the semaglutide groups and placebo group. Now, what about semaglutide for patients with cirrhosis? Here's another phase 2 RCT on 71 patients with NASH cirrhosis with a BMI of at least 27. Patients were randomized to semaglutide 2.4 milligrams weekly or placebo. At 48 weeks, there was no difference between the 2 groups in the proportion of patients who experienced an improvement in fibrosis by at least 1 stage without worsening of NASH. 11% in the semaglutide group versus 29% in the placebo group. The SAE rate was similar between the 2 groups. So these 2 studies together suggested that semaglutide may be beneficial for patients with NASH, but probably not if they have already progressed to cirrhosis. Now, what about all GLP-1 receptor agonists as a drug class? Here's a meta-analysis of 11 phase 2 RCTs of different GLP-1 agents versus controls, including a total of 936 patients. Of these, 6 studies used liraglutide, 3 used exenatide, 1 used dulaglutide, and 1 used semaglutide. All studies use GLP-1 receptor agonists to specifically treat NAFLD detected by histology or imaging. The study showed that treatment with GLP-1 receptor agonists was associated with greater reduction in the amount of liver fat content on MR-based techniques, as well as greater histologic resolution of NASH without worsening of fibrosis. However, there was no difference between the GLP-1 arm and control arm in terms of the proportion of patients who experienced an improvement in fibrosis stage without worsening of NASH. Now let's shift gears and look at the data on bariatric surgery and NAFLD. Here's a study that was published in Lancet last month. It's a multi-center, open-label randomized trial of patients with obesity and histologic NASH. Patients were randomized 1:1:1 to lifestyle modification, Roux-en-Y gastric bypass, or sleeve gastrectomy. All patients underwent percutaneous liver biopsy at months 0 and 12. What they found was that at 1 year, the gastric bypass and sleeve gastrectomy groups did significantly better than the lifestyle modification group. Specifically, 56 and 57% of patients in the gastric bypass and sleeve gastrectomy groups experienced resolution of NASH without worsening of fibrosis, compared to 16% in the lifestyle group. Additionally, 37 and 39% of the gastric bypass and sleeve gastrectomy groups had an improvement in fibrosis by at least 1 stage, with no worsening of NASH, compared to 23% in the lifestyle group. So now that we have seen some data on lifestyle modification, pharmacotherapy, and bariatric surgery, you may wonder why we should consider bariatric endoscopy for NAFLD. By now, we learned that less than 10% of patients who undergo lifestyle modification are able to achieve the 10% total weight loss threshold. We also learned that there's no pharmacotherapy specifically approved for NAFLD, and data on semaglutide or NAFLD are still limited. Furthermore, while bariatric surgery is effective at treating fatty liver, less than 2% of eligible patients choose to undergo bariatric surgery. Therefore, we need a treatment alternative that is more effective than lifestyle modification, but less invasive than bariatric surgery. When we talk about bariatric endoscopy, currently there are 4 devices and/or procedures that are approved or cleared for the treatment of obesity. These include Orbera intragastric balloon, ESG, POSE, and Endomina. As you can see in the table here, the amount of weight loss with intragastric balloon is about 10 to 12%, and the amount of weight loss for ESG, POSE, and Endomina ranges from 15 to 18% at 1 year. Let's start with a case. Here's a patient of mine. She's a 29-year-old woman with a history of Down syndrome, hypothyroidism, and NASH. Her BMI was 37.8. She underwent liver biopsy at an outside hospital, which showed grade 2 steatohepatitis and stage 1 fibrosis. Her sister underwent liver transplant, of which she would like to avoid. After discussing different treatment options for weight loss, she decided to proceed with a balloon placement. At 6 months, we removed her balloon and her BMI went from 38 down to 23, representing a 39.2% total weight loss. Additionally, we performed an EUS-guided liver biopsy at the time of balloon removal, which showed complete resolution of both steatohepatitis and fibrosis. So one may consider bariatric endoscopy for patients with NAFLD when they do not qualify for bariatric surgery because their BMI is too low, or when they do not wish to proceed with bariatric surgery. So what's the data on intragastric balloon and fatty liver? Here's an RCT from Singapore looking at patients with a BMI of at least 27 and histologic NASH. They randomized patients into balloon plus lifestyle modification or sham plus lifestyle modification. At 6 months, there was a greater reduction in NAS in the balloon group. Specifically, while the baseline NAS was similar between the two groups at the beginning, 5 and 5, at 6 months, the follow-up NAS was 2 in the balloon group compared to 4 in the control group. Now, moving on to ESG and POST. These are endoscopic weight loss procedures where we use a suturing or plication device to reduce the gastric volume by about 70%. For ESG, we use the overstitch suturing device, which recently received de novo authorization for the treatment of obesity. It's widely commercially available. So what's the data on ESG and fatty liver? Here's a study from Reem Sharaya at Cornell. She looked at 118 patients with obesity and NAFLD who underwent ESG. In the study, they defined NAFLD as having a hepatic steatosis index score of greater than 36. At 2 years, patients experienced 15.5% total weight loss. Additionally, if you look at the graph on the right, the proportion of patients with F3 to F4 fibrosis decreased from 11% to 7%, and the proportion of patients with F0 to F2 increased from 43 to 61%. Now, moving on to POST, which refers to when we use a plication device to reduce the gastric volume by about 70%. This endoscopic plication device is cleared by the FDA for tissue approximation. It's commercially available at limited centers. So what's the effect of POST on NAFLD? Here's a study from our group looking at 45 patients with obesity, NAFLD, and F2 to F4 fibrosis. All patients underwent POST successfully. At 12 months, there were significant improvements in non-invasive tests for hepatic fibrosis. Specifically, ALT decreased from 49 down to 24. There were significant improvements in NFS and FIB-4 scores. Furthermore, on FibroScan, liver stiffness score went from 13.9 down to 8.9 kilopascal. Additionally, patients experienced about 15.5% total weight loss at 1 year. For secondary outcomes, there were significant improvements in the CAP score, HOMA-IR, and hemoglobin A1C, suggesting an improvement in insulin resistance. Let's look at another patient of mine. She's 68 with class 3 obesity and compensated NASH cirrhosis. Her BMI was 42.4. She actually went to the OR for an attempted Roux-en-Y gastric bypass, which was aborted due to cirrhosis. The surgeon then sent the patient to me for consideration of endoscopic sleeve gastroplasty. On her workup, her ALT was 60, platelets 120, and INR was 1.1. Her meal sodium was 18 with Chiappuch class A. On FibroScan, her liver stiffness score was 17 kilopascal. At that time, since we did not know if it's safe to perform ESG in patients with cirrhosis, we decided to do more workup to assess if she had portal hypertension. Traditionally, HVPG measurement can be performed by our IR colleagues to determine if patients have portal hypertension, which is defined as when an HVPG is greater than 5 mm mercury. More recently, we can also perform EUS-guided portal systemic pressure gradient or PPG measurement to assess for portal hypertension. As shown in the cartoon here, we pass a 25-gauge needle into the hepatic vein and portal vein to measure their pressures. The difference between these two pressures represents the PPG value. Here's a video of EUS-guided PPG measurement. We first pass a 25-gauge needle into the hepatic vein. This needle is connected to the barometer, which reads the pressure of the vessel. At least 3 pressures are obtained, and the average number represents the hepatic venous pressure. Subsequently, the same steps are repeated for the portal vein as shown here. The difference between the portal venous pressure and the hepatic venous pressure represents the ppg value. This patient then underwent a post-procedure successfully. At 9 months, her BMI went from 42 down to 38, representing an 8.6% total weight loss. On FibroScan, her liver stiffness score went from 17 down to 7.6 kilopascal, and her ppg went from 11.5 millimeter mercury down to 8 millimeter mercury. So another indication to consider bariatric endoscopy for NAFLD is when patients do not qualify for bariatric surgery due to being deemed too high risk, such as those with cirrhosis with clinically significant portal hypertension. We then decided to conduct a study to assess the effect of POST on ppg. Here's a single-center study of 20 patients with obesity, NAFLD, and F3 to F4 fibrosis. All patients underwent EUS-guided ppg measurement before and at 6 months after POST. Of our cohort, 50% had possible portal hypertension, defined as a ppg of greater than 5 millimeter mercury. Additionally, 25% had possible clinically significant portal hypertension, defined as a ppg of at least 10 millimeter mercury. If patients had a baseline ppg of at least 12, we started them on a non-selective beta blocker prior to undergoing POST. All patients underwent POST successfully. As you can see in the graph on the right, there was a significant improvement in ppg at 6 months following POST. Specifically, the median ppg went from 5.4 down to 1.8 millimeter mercury. Additionally, about 80% of the cohort experienced at least 20% reduction in ppg, which was previously deemed to be a threshold for a reduction in risk of variceal bleeding and death. And last but not least, our group conducted a meta-analysis looking at the effect of bariatric endoscopy as the whole field on NAFLD. This meta-analysis included 18 studies with about 860 patients. Of these, 14 studies were on intragastric balloon, 2 studies were on ESG, and 2 studies were on aspiration therapy. Of note, this meta-analysis was conducted before our POST studies were completed. At 6 months, the amount of weight loss was 14.5%. Additionally, we showed that there was a significant improvement in liver fibrosis, ALT, hepatic steatosis, and NAS score following endoscopic bariatric and metabolic procedures. In conclusion, lifestyle modification is the mainstay of treatment for NAFLD. Currently, there are no medications specifically approved for the treatment of fatty liver. Anti-obesity medications, in particular GLP-1 receptor agonists, may be a promising treatment option. And bariatric surgery is an effective treatment option for NAFLD. However, right now, less than 2% of the patients who are eligible choose to undergo the surgery. Currently available endoscopic bariatric and metabolic therapies are safe and effective at treating obesity and fatty liver, including those with cirrhosis and portal hypertension. Endoscopic bariatric and metabolic therapies may be considered for patients with NAFLD who do not qualify for bariatric surgery because their BMI is too low or because they're deemed to be too high risk, such as those with portal hypertension, or they do not wish to undergo bariatric surgery. And last but not least, future studies exploring endoscopic bariatric metabolic therapies, mechanisms for improvement in fatty liver, and outcomes of combination therapy with pharmacotherapy are needed. Thank you very much.